Thank you. My name is Karen Coughlin. I am from Mansfield, Massachusetts. I am a nurse and the Vice President of the Massachusetts Nurses Association, M&A. My colleague, Donna Kelly-Williams, spoke on behalf of M&A at the hearing last Wednesday. I'm here today to speak on a few additional items that Donna was unable to cover in the time that was allotted last week. The M&A in Donna's testimony last week addressed several concerns we have with the proposed regulations as they relate to the acuity tool. I will not reiterate those concerns here today, but will raise some additional concerns. The first is that there should be some direction in the regulations that the ICU acuity tools developed by the hospitals be specific to that hospital and the specific ICU or ICUs in the hospital, be it a general medical surgical ICU, a burn unit, or a NICU. Each of these units would require different conditions and elements to be part of the final acuity tool. The acuity tool cannot be cookie cutter. It must be developed with the ICU staff nurses and specific to the unit and to the hospital. When the M&A reached out to several of the manufacturers of existing acuity tools, they did not indicate that it would be difficult to create these types of specialized acuity tools. Also, in addition, in relation to the acuity tool development and selection at hospitals where nurses and other healthcare staff are represented by unions, the union should be involved in selecting the members of any committee working to develop and approve the acuity tool. Whether it's the M&A representing nurses or another union representing other healthcare workers and ancillary staff, the union should decide who is on these committees. Direct care nurses must comprise at least 50% or greater of these committees, and we cannot allow them to be handpicked by hospital management. As Representative Denise Garlick noted last week in her testimony, unless you ensure that the workers and their unions select the appointees to these committees, they and any tools they develop will be meaningless. Finally, I wanted to take a moment to dispel the notion that there are any quote-unquote gray areas around what it means for a nurse to accept an assignment. A patient is assigned to a nurse, and the nurse takes that assignment under his or her license. If for any reason, the nurse must leave the unit, for example, to take a patient for x-rays on another floor, any second patient that might have been assigned to that nurse is now reassigned to another nurse who is on the unit. There is no such thing as covering a patient for another nurse. The patient is assigned to a nurse, and it is that nurse's responsibility until discharge or being reassigned to another nurse. And this law is in effect at all times. We thank the HPC for reiterating that in the regulations.
Thank you so much.
Thank you.
I appreciate that.